First, we would be having a speaker that would be by Dr. S.V.S. Deo, sir, and then a panel discussion. Firstly, I would like to request Dr. Arun Goyal, sir, Director Surgical Oncology, to kindly give a welcome note, and then we get started with the webinar. Thank you.
Thank you, Dr. Chirag. Once again, it's a pleasure and an honor for our team to host this webinar, Focus Studies in Breast Cancer. And as I have always said, what started with COVID is something which I believe is going to be a permanent feature. And I believe it is a very important part of how we are going to handle academic events in the coming times. It allows us to have the best of faculty from all over the country and all over the world. At the same time, people from all over the country and even outside the country are able to get the benefit of such events. And it saves time and effort for a lot of people. So as Dr. Chirag highlighted, it is the 26th webinar, and in addition to this, we have also done 2 conferences, and time is now coming near where we may be planning our 3rd conference. It's nearly 1 year from the last event. And the topic today is ipsilateral breast tumor recurrence. Overall, while the number of recurrences is going down as we are seeing more earlier and earlier breast cancers and are integrating multimodality treatment, but we have a wonderful opportunity to achieve a sort of good long-term survival and cure in a significant percentage of ipsilateral breast tumor recurrences. And so it's important to identify which are those patients who can benefit from potentially curative treatment and those who otherwise may not be cured but would have good quality of life, which can be fairly long. So it is definitely always a pleasure to see all the faculty and meeting with Dr. Dev, with whom I have had an opportunity to work for a fairly long time at AIMS. So I'll hand over to Dr. Chirag to get the proceedings going. Thank you once again.
Thank you, sir. So as discussed, we would be first moving on to a lecture, a talk by Dr. S.V.S. Deo, sir, who needs no introduction. It's a great opportunity for all those who join this webinar to listen to sir, because it's every time we listen to sir, it's refreshing, and there is so much subject that goes into it. So the topic would be an overview basically on ipsilateral breast tumor recurrences. Handing over to you, sir. Thank you.
Yeah, thank you, Chirag. Just let me share my slides if you allow me. Yeah, can you see my slides, Dr. Arun?
Yes, sir. Yes, sir.
Yeah, am I audible?
Yes, sir.
Yes.
Yeah, thank you. At the outset, I would like to thank the Indian Anti-Cancer Trust, I think led by Dr. Rajiv, Dr. Arun, Dr. Vaishali, the very passionate group. And it's always a pleasure interacting with this group. Arun, we have a long association with Dr. Rajiv. And whenever I think I get a call, I think I'm really eagerly looking forward for these interactions, because as Arun has said, I think the pandemic has given us a new opportunity to dig deep and focus on topics which we are not able to do before the pandemic. Mostly they were general sort of conferences covering everything, but now we are going into, we are able to dig deep into each and every topic and learning a lot. I think with that, I would like to start my talk. I've been asked to give an overview on the ipsilateral breast tumor recurrences. So this is a topic which is not often discussed. We mostly confine our discussions to breast conservation therapy, oncoplasty, sentinel lymph node biopsies. But the IBTR has been neglected, I think, in the most of the academic events. But as Arun has said, with the increasing breast cancer early detections, better treatments, increasing cure rates, and a very intensive follow-ups, we are likely to see a good number of these patients coming with ipsilateral breast tumor recurrences. So this overview, I'm going to just briefly give you. So what is the current status of diagnosis, the criteria used for defining IBTR, the management approach, including all three modalities. This we have just highlighted with the increasing survivals. Now BCT has become standard of care. The current locoregional recurrences reported globally range between 5 to 15%. We have three standard models which we have been discussing for the last 3 to 4 decades, whether breast cancer is a systemic disease or a mechanistic theory proposed by Halstead. It's a locoregional disease, or I think what we have actually now reached a consensus. It is actually a spectrum hypothesis proposed by Helmers that breast cancer is a heterogeneous spectrum of disease, where I think the local control is extremely important in the overall outcomes and controlling systemic disease. If you look at the therapeutic era of breast cancer, from 1900 to 70s, it is predominantly dominated by locoregional therapies with a high rates of locoregional recurrence. And then we entered the era of systemic therapy in the 70s with introduction of CMFs, then anthracyclines, then taxanes, then targeted therapy. We have actually entered the era of systemic therapy, which was played a dominant role from 70s to 2000. With the overall improvement in the outcomes of breast cancer. Of course, a lot of other factors have also played a role, including screening, early detection, breast conservation therapy, radiotherapy, everything progressed during this era. Now we have entered the era of personalized and precision medicine in the current era. What we are fighting for is improvement of 1 to 3%, 1 to 2% with each modality. That is where we stand now. That is where all the crux of the matter comes when you are treating early breast cancer. Locoregional recurrence is clinically a significant event in the natural history of breast cancer. 5 to 15% of breast cancer patients can experience locoregional recurrence. Reflection, it is a reflection of tumor biology or sometimes suboptimal therapy, especially in developing countries. Sometimes if you see a lot of patients coming from referral from primary centers, suboptimal treatment, incomplete mastectomies, incomplete lumpectomies, margin positive lumpectomies, there are multiple factors, which is a reflection of biology as well as the kind of treatment which is offered. And the timing of locoregional recurrence can be either early or late, which has a prognostic significance. And locoregional recurrence can be an harbinger of systemic metastasis, has been shown in literature up to almost 1/3 of patients with locoregional recurrence can also have associated systemic metastasis. IBTR, the long-term survival because of close surveillance, increased detection is happening. After breast conservation therapy, IBTR, ipsilateral breast tumor recurrence, is reported in 8 to 20% of patients. It also dependent on the duration of follow-up. There are certain types of IBTR you see in the first 5 years. There are certain types of IBTR or second primaries you come across in the long-term follow-up. So there is a hypothesis we need to understand. We cannot club everything as IBTR. There are entities which can be called as true local recurrence, and there are entities which are actually new primary tumors. We need to know how to differentiate because the outcomes are different, the treatment approach is different. Individuals with new primaries may have a genetic predisposition and are therefore at risk of new primaries. And optimal management of patients with IBTR after BCT is still not well defined. If you look at the overall locoregional recurrence, the patterns globally, we have been doing very well. We have the rates in 70s and 80s, 90s and 2000. It has come down to 10 to 15% from 15 to 30. And in the current era, most of the single institutional large studies with quality control treatment, the locoregional recurrence are less than 5%. These are some of the studies I picked up. Very big studies with at least 10 years follow-up. If you see locoregional recurrence or less than 10%, mostly around 5 to 6%. And single institutional studies like EIO, it is published from Milan, it's around 1 to 2%. And this is a very elegant IBTR studies done from Edinburgh. You can see 4 decades they have documented the IBTR rates. Starting from 80s, 90s, 90 to 2004 decades, they have divided. At the 5 years and 10 years, you can see the IBTR rates are going down. It used to be around 6 to 10% in the cohort treated in the 80s and 90s, and currently it is around 1 to 5%. Even Indian data is available for IBTRs. We have a Tata paper by Dr. Dinsha, around 9%, and we have our own paper from AIMS, which has shown a 3% IBTR rates following BCT. So what is the impact of loco-regional control on overall survival? There was a debate when systemic therapy was coming in a big way in the 80s and 90s, that loco-regional control is not important. But this elegant meta-analysis, EBC-TCG meta-analysis has shown that loco-regional control is extremely important to control mortality, breast cancer mortality. And at 15 years, for every 4 local recurrences you prevent, you can save 1 breast cancer life. Local regional recurrences can be classified into local recurrence, and which can be again subclassified into post-BCT local recurrence, that is called IBTR, which again can be a true recurrence or a new primary tumor. The second category of local recurrence is post-mastectomy chest wall recurrence. Then you have a combination of loco-regional recurrence and a combination of loco-regional and systemic recurrence. This is how you do a working diagnosis when you see a patient coming back with a local recurrence. You need to differentiate various entities. Ipsilateral breast tumor recurrence can be a true infield recurrence, means relapsing at the treated site, recurrence at the treated site, at the boost, at the site of lumpectomy. So these are called real true infield recurrences. Almost 60 to 70% of the IBTR are true infield recurrences. Marginal recurrences we can see in the vicinity of the treated area. And outfield recurrence is a recurrence away from in a different quadrant of the breast. So these are called outfield. These are the various terminologies we should understand. So these are a few pictorial diagrams. You can see any recurrence happening in the treated breast is the infield recurrence. So this is a marginal recurrence in the vicinity of the treated breast. And if it happens somewhere in a different quadrant, it can be a second or a new primary tumor. So your clinical assessment is extremely important. And you can also classify IBTR based on the type of presentation, which can be unifocal, which can be multifocal. Sometimes you can have in the ipsilateral breast diffuse or inflammatory or cancer in cuirass types of relapse involving predominantly the skin and lymphovascular systems. IBTR can also be time dependent. We have there are early IBTR happening in the first 2 years, or late IBTRs, which can happen 5 to 15 years after therapy. There are certain differences between post-mastectomy loco-regional recurrence and post-BCT loco-regional recurrence. Most of the post-BCT local relapses, they happen little later part. They have a low incidence of regional and systemic relapse compared to post-mastectomy relapse. And majority of them mammography detected. They are more amenable for surgery, and the prognostic and treatment outcomes are better than post-mastectomy recurrences. Coming to classification, how do you classify IBTRs, ipsilateral breast tumor recurrences? The Huang et al. Is a classical paper. They have described the 2 types of tumors in the IBTR, a new primary, which is NP, or a true recurrence. So they can be differentiated based on the tumor location, histopathological type, and molecular subtypes. Of course, these classification systems have not been standardized, and there is no uniform application of these criteria. Majority of the series or data, if you see, most of them are labeled as IBTRs. So, but you should document the type of IBTR whenever it's possible. So the first type of classification method, where it is described the IBTR as either a new primary or a true recurrence based on the location and histological subtypes. If the IBTR is designated true recurrence, if it is located within 3 centimeters of the primary tumor bed, either clinically or radiologically, and if the histological subtype is consistent with the primary, it is called a true recurrence. And if the ipsilateral breast tumor is more than 3 centimeters from the primary tumor site, and if the histology is different, it is designated as a new primary. So this is one classification system. The second system is based on the tumor location, histological subtype, and ER, PR, and HER status. IBTR is designated if the true recurrence, if it is located within 3 centimeters of the primary bed, if histopathological subtype is same, and HER status are also same, then it's called a true recurrence. If it is not fulfilling any of these criteria, you can label them as second or new primaries. So what is the impact of IBTR on distant metastatic survival? It has been shown, Fisher, actually all the NSABP data is pulled to look at the impact of on survival, the impact of IBTR, and they have clearly shown it is an independent predictor for distant disease, almost with a 3.4-fold increase in the risk of distant relapse. And most of the patients with IBTR had worse disease-free survival than patients with isolated IBTR. So these are certain survival curves you can see here in the lower two graphs. The patients with locoregional recurrence with short disease-free interval, medium disease-free interval, and long disease-free interval, there's a big difference in survival. The shorter the disease-free interval, the worse is the survival. You can see the lowermost plots here. This is for the second primary. The survival is slightly better on the right side compared to true local recurrence. Second primary outcomes are better. Again, the disease-free interval plays a very important role as a prognostic factor. Local therapy and survival, very excellent review in NEJM. I request all the surgical residents to read this article. So on the right side, you can see the impact, how far the local recurrence can impact the overall survival. Beyond a point, doing extra surgery or big procedures is not going to contribute for survival. So this is what this curve shows. The increasing effectiveness of systemic therapy, then the impact of local therapy goes down beyond a point. How do you diagnose and stage ipsilateral breast tumor recurrence? We have post-mastectomy, it is clinical diagnosis. Post-BCS, it is image or clinical detected. Restaging is mandatory, and whenever you suspect IBTR, you can do a PET scan or a standard CT and bone scan. Biopsy is mandatory. So most of the imaging that is used is either a mammogram or ultrasound, and in difficult cases, you go for MRI because there are challenges in diagnosis because you are dealing with treated breasts with a lot of fibrosis, increased density, post-treatment changes. It's very difficult to interpret on mammogram sometimes. Even MRI is going to be challenging. So the radiologist has to be experienced. PET also adds value in proper staging of patients with ipsilateral breast tumor recurrence. So you can have upstaging of the disease, especially with PET. It can detect non-regional lymph node metastasis. So this is a study showing role of MRI in ipsilateral breast tumor recurrences. It has showed that it adds value, especially to assess the size of the tumor and multifocality. So what are the risk factors for ipsilateral breast tumor recurrence? After breast conservation surgery, it is positive margins, younger age, lack of systemic therapy, closed margins, lymphovascular invasion, node positivity. All these are risk factors for IBTR. So there are certain treatment factors which can influence IBTR. So coming to surgery, surgery is the mainstay. The quality of surgery for the first tumor is extremely important. We can have high locoregional recurrence in patients who are having margin positivity. Suboptimal surgical resections can lead to high IBTRs. So breast surgeons should generally avoid dilution of surgery for treating breast cancer and over dependence on adjuvant therapies. This is extremely important. If you do your first job well, you will see less of IBTRs. Similarly, an impact of radiotherapy on locoregional recurrence. This has been shown in a number of studies. Radiotherapy decreases IBTR by almost 50%. Systemic therapy also can play a role in decreasing IBTRs. We have various studies here showing impact of chemotherapy, hormonal therapy, and trastuzumab having an impact on IBTR incidence. Prognostically, yes, there is a paper published in JCO, IBTR, how it affects the prognosis and survival. So they have included 2,669 women and node positive treated with systemic therapy, 15.9% experienced locoregional failure, 9% IBTR, 6% locoregional recurrence. The 5-year overall survival rates for IBTR and other regional recurrence is around 60%. So there is an impact on the survival in patients with IBTR. So these are various NSABP studies showing the IBTR's rates over a period of time. Molecular subtypes can also influence locoregional recurrence. Now we have a lot of data coming. There is a clear correlation between molecular subtype and IBTR rates. We have the lowest IBTR in luminal A, ranging from 1 to 3%, and highest IBTRs and locoregionals in HER positive and TNBCs, ranging between 5 to 15%. This is what the current literature says. And we also have recent trials showing by the Swedish group that HER positive tumors seems to be more radioresistant, and luminal tumor seems to demonstrate an outstanding effect from radiotherapy. Certain TNBC tumors who have epidermal growth factor receptor or CK positivity also demonstrate radioresistant and can lead to higher IBTR rates. Coming to an overview of management approach for IBTRs, the intent of therapy should always be cure. Whenever you see a patient with IBTR, that doesn't mean he has a relapse and you go decrease the threshold of treatment or go for palliation. Your intent should be surgery, curative. So coming to various options, surgery plays an important role in IBTR. We have two options: salvage mastectomy or repeat BCS. Radiotherapy also plays an extremely important role, especially in the form of re-irradiation. It can be either external beam radiation. Brachytherapy is very integral part for IBTR treatment, and we have recent literature coming with APBIs and IVORT. Systemic therapy also plays an important role when you are dealing with IBTRs. Surgical options, when you see IBTR patient, is we have two standard options. Salvage mastectomy is the standard of care, but we also consider re-BCS is an option in a small subset of patients. And most of the re-BCS experiences from single institutions and small studies. Factors which can affect when would you like to decide whether to go for a mastectomy or BCS will depend whether it is a unifocal or multifocal, suitability for BCS, whether you can achieve a good cosmosis, what happened with previous radiation, quality of breast tissue, size of the breast. There are multiple factors which play a role when you decide for re-BCS or salvage mastectomy. So these are ideal patients for re-BCS: isolated, unifocal tumors, small size, elderly age, long interval between primary and the recurrence, and of course, patient desire for re-BCS. Sometimes they are reluctant. They say, we have taken a chance, we want to go for a mastectomy. So if the patient is motivated, we can definitely offer re-BCS. Certain studies with re-BCS, you can see the local control rates ranging between 19 to 30%. Small studies, of course. Then this is a Korean study which has shown 210 patients. There is no significant difference between mastectomy and BCS when they offered surgery to IBTR patients. This is a meta-analysis comparing mastectomy versus BCS in IBTR patients. The conclusion is the secondary local recurrence of re-BCS is higher than mastectomy, of course, but there is no impact on survival. It does not affect the survival whether you do a mastectomy or re-BCS. Role of re-irradiation, we have a lot of data, mostly brachytherapy data. The JAC-ASTRO study, the largest experience, which has shown a local control rate, excellent local control rates with a recurrence rate of 5% using brachytherapy following IBTR re-BCS. Then we have certain studies showing the role of a small series and also some experience with intraoperative radiotherapy. Few studies have shown a good outcomes for re-irradiation. So these are certain studies using repeat BCS and re-irradiation, where most of the studies have used brachytherapy, small number of patients, but you can see on the right side, excellent local control ranging between 70 to 90%. But the key is patient selection. Systemic therapy plays a very important role, but it is not well defined in the setting of IBTRs, whether you should go for neoadjuvant or adjuvant. So there are various controversies, but all depends on what kind of systemic therapy patient has received for the primary tumor, what kind of chemotherapy, what is the disease-free interval, and what is the molecular subtype of the tumor, the recurrence. So based on that, you take a call. If it is salvageable, operable patient, normally they go for upfront surgery followed by radiation, and they are offered secondary adjuvant chemotherapy or hormonal therapy or Herceptin based on the molecular profile of the IBTR. The role of chemotherapy in IBTR patients, we have a very good randomized trial, CALOR trial, where they have shown that addition of chemotherapy following treating local recurrence adds to survival. So this is proven. And systemic therapy, as I told you, there is no large scale, high level evidence. Mostly treatments are individualized based on the previous systemic therapies, molecular subtypes, disease-free intervals, and performance status. Now we are entering the era of molecular biology for ipsilateral breast tumor recurrences. This is one study I came across, a very elegant and very comprehensive study where they have actually picked up, I think, 29 or 30 tumors, where they have done the complete multi-omic analysis of the primary tumor and ipsilateral breast tumor recurrence, whether to see the clonal origin of the tumors is the same or is the gene signatures of the patients with IBTR is different. So it is a fantastic study. And what they have shown in this study, that there's a unique comprehensive study with using multi-omics. The analysis revealed a relationship between hormonal receptor status and proliferation levels, resulting in a gain of somatic mutations and copy number in IBTR patients. This in turn reprogrammed the transcriptome and proteome towards a highly replicating and genomically unstable IBTRs, possibly enhanced by apoptosis gene. So in conclusion, what they've said is the breast tumors evolve into different IBTRs depending on the hormonal status and proliferation and immune cell infiltration and Ki-67 levels of the primary tumor, and that can develop into IBTRs. So this is actually shown how these tumors transform into IBTRs, and the behavior is different and the gene signatures are also different. Even though the molecular subtyping may be same or histology may be same, but if you dig deep and go to the molecular level, they exhibit a different signatures. Then just to, before I wind up, there are certain gene signatures. I think you all are familiar nowadays. We are using Oncotype DX, PAM50, MammaPrint. So they are good predictive and prognostic tools. They can also predict the risk of IBTRs. This has been validated for local regional recurrence, mainly with 20 gene recurrence score, that is Oncotype DX. Coming to our own data at AIMS, I have evaluated. Now we have almost 4,500 patients and 1,000 breast conservation surgery data we have analyzed. The IBTR rates in the Indian setting, comprehensively treated and followed up, we detected 3.76%. With a median follow-up of around 7 years, 3.76. And almost 90% of our patients went for salvage mastectomy, and we could do re-BCS in a small percentage, that is 10% of patients. So this is what these slides are showing. So just to wind up my talk, these are the molecular subtypes and local regional recurrence or IBTRs, our own data from AIMS. You can see the local recurrence ranging. It's slightly higher in the TNBC and HER patients compared to luminal patients. So just to conclude my talk, IBTRs is a very interesting and challenging entity. We are going to see more of these IBTRs in the current era of very aggressive treatment for primary tumors and intensive follow-ups with imaging and MRIs. We are likely to see more of these patients. So you should have in mind your treatment should be, the intent should be cure whenever you detect IBTR. There are challenges in the diagnosis. The imaging modalities you use, your radiologist should be very experienced. You should go for MRI whenever there is a doubt in mammographies. And histopathology also plays an important role. Please get in touch with your pathologist, go back, see the primary tumor morphology, molecular subtyping, and match with your recurrence. So it gives you a lot of information whether you are dealing with a true local recurrence or a new second primary tumor. Then you also have to discuss with your radiation oncologist what kind of radiation has been given, what is the disease-free interval, whether it is feasible to go for re-irradiation. So multidisciplinary approach is extremely critical when you are dealing with IBTRs. Radiology, pathology plays an important role in the diagnosis, and you need to interact with your radiation oncologist and medical oncologist to plan systemic therapy or re-irradiation. And surgical decision will depend on various factors. Of course, salvage mastectomy, the treatment of choice, but you should also keep re-BCS with re-irradiation in a subset of patients. With that, I would like to conclude my talk. In surgical oncology, as Blake Caddy has said, biology is the king, selection is the queen, technical maneuvers are the prince and princesses. That is, I think, still valid even in the era of your precision and personalized medicine. Thank you very much.
Thank you, sir. It was indeed a excellent talk on a very, as you said, a very rarely discussed topic. And I'm sure all of us have come out more wise in our knowledge on IBTRs. I would request you to be there throughout the webinar, sir, for the panel discussion. Yes, sir. And also for the audience, we would be happy to answer questions at the end of the panel discussion. Thank you, sir.
Thank you. Thank you, Dr. Chirag. I will stay.
So now would be, to make this more interesting, we would be having a case-based panel discussion. So I would like to first introduce the moderators for the panel. Firstly, Dr. Prekshi Chaudhary, who is a Senior Consultant Radiation Oncology at Max Super Specialty Hospital, Vaishali, Ghaziabad. And Dr. Safalta, who is Associate Professor, Medical Oncology at Amrita Institute of Medical Sciences, Faridabad. Dr. Vaishali Zambre, who is Senior Consultant and Unit Head, Breast Oncology at Rajiv Gandhi Cancer Institute, Delhi. And the panelists for the panel discussion. Firstly, Dr. Garvit Chitkara, sir, who is Senior Consultant, Department of Breast Surgical Oncology at Nanavati Max Super Specialty Hospital. Dr. Richa Bansal, Principal Consultant, Department of Radiology at Max Saket. Dr. Nidhi Patni, who is Director and Head, Department of Radiation Oncology at Bhagwan Mahavir Cancer Institute, Jaipur. Dr. Anku Vashne, who is Consultant, Department of Medical Oncology and Stem Cell Transplant at FMRI, Gurgaon. Dr. Dheeraj Gautam, who is Director, Laboratory Medicine, Pathology and Blood Bank at Medanta. And Dr. Neha Pathak, Assistant Professor, Department of Medical Oncology, ILBS, Delhi. Over to Dr. Prekshi to go ahead with the panel discussion.
Thank you, Dr. Chirag. Are my slides visible?
Yes.
Yes.
Okay. And thank you, Dr. Chirag, and thank you, sir, for this elaborate discussion of this topic, which is a bit less talked about. And I think you have almost covered all our panel discussion and all the answers have been given, but still we'll have a reiteration of the facts in a practical case. So a warm welcome to all the panelists. So we'll start with the case. A 50-year lady presented with left-sided breast lump in year 2023 itself. She had a personal history of left-sided breast cancer, which was diagnosed and treated in 2006. That was, and at that time, she was 33 years old. First of all, we'll have a look at the first event, that is 2006. At that time, she presented with a left axillary lymph node, and FNAC was carried out from the same, and it was suggestive of breast cancer. However, even after aggressive imaging, no primary could be found. So she underwent an outer quadrantectomy and axillary lymph node dissection. On histopathological examination, the pathologist was able to find a T1 lesion in the breast specimen. 3 out of 13 lymph nodes were positive, so she was pathologically T1N1. She was triple negative. After that, she received 6 cycles of FEC followed by radiation therapy. Then she was on regular follow-up till 5 years, after which she was lost to follow-up. Then in 2023 March, she presented with a lump in outer quadrant of the same breast. So I want to ask Dr. Garvit, how would you like to proceed in this case?
So I mean, for a lady who's now 50 years of age and has presented with a recurrent breast cancer or an ipsilateral breast tumor recurrence, as we call it, I would like to go as per the triple test, do a clinical examination, do a mammography, and do a core biopsy from the lump. And after I have found out what it is, and if it is a breast cancer, I would want to do a metastatic workup to see whether there is any, is it truly a local recurrence, a local regional recurrence, or a systemic recurrence, as Dr. Deo just put it so nicely in his presentation. And if there is a node, I would also like to do an FNAC of that node.
So it will be same as that of the primary setting, and in no way it is different from like.
Yes.
Yeah. And yes, you have told, would you like to please reiterate how can we differentiate a true primary from new primary from a true recurrence? Sir has already mentioned also.
So sir has already mentioned that, but there is one thing that I think we can still think about. Like you said that the previous primary was triple negative breast cancer.
Yeah.
So one is the location of the tumor. If it is at the site where it was primarily, it's a true recurrence. If it is at the site of the margin, it's called a marginal recurrence. And if it is in a different quadrant, it could be a second primary or a distant recurrence, or a true recurrence, as in away from that. Now, the other way, when we try to look this up, we also try to see if there has been a change in the histology of the tumor. So for a triple negative, I can expect a triple negative to remain a triple negative. Generally, a recurrence would come with a dedifferentiation of the tumor. A new primary which has come as an ERPR positive, if it comes as ERPR positive, I would like to consider this as a second primary rather than a recurrence of triple negative breast cancer. But that is a general rule, and especially if the now this one was a slightly difficult one, and this is about 13 or 17 years ago. If there is a presence of DCIS in the primary that we have found right now, it's more likely to be because of the nature of how the disease progresses, it is more likely to be a new primary.
So location of the tumor, histology, IHC have to be considered. And do you think duration, does it have any role? Like,
so duration will obviously have a role, but duration is not a absolute this thing to say that whether this is going to be, yes, in the definition it makes a difference, but 17 years later it's anybody's guess. I would want to call it a second primary.
Exactly. Dr. Nidhi ma'am, what do you think are the risk factors for recurrence? Yes, I will again say that sir has mentioned in his talk, but what are the risk factors of recurrence in BCS patient? And I mean, can we stratify a subgroup, like which is at higher risk or which is at lower risk, in which we can subject the patient on aggressive surveillance?
Yes, so it can be classified in two different categories. One is patient related and the other is tumor related. So whenever the patient is young, there is a poor histology, we know, and the younger age comes with a TNBC more frequently, and younger the patient is more likely is she and the family to opt for a BCS. And in a case where there is a high chance of BRCA positivity, we know that though there is no randomized trial or any data to say that BCS should not be done in BRCA positive patients, but we can understand that the biology is aggressive for such patients, and these patients are likely to recur since they are going to live for a longer period of time, considering the age at diagnosis. But yes, at the same time, the contradiction is that the histology per se is aggressive for these patients. Again, coming to the tumor and the way it is treated, there could be a marginal recurrence also, and in tumor recurrence also, if the boost is not given properly, or the histology is aggressive per se. Suppose there is LVAI positivity and triple negativity in the tumor, then there is a higher chance of the recurrence IBTR in such patients.
Okay, ma'am. So all these factors need to be considered while putting the patient on surveillance. Right then, this Dr. Richa, I would like to ask, on a follow-up mammogram, what are the features based on which we can differentiate that it is a scar or a recurrence?
Basically, on a follow-up mammogram, mainly what we see is scarring in the region of the surgery, which may be associated with skin and trabecular thickening. There may be nipple distortions. There may be dystrophic calcifications due to fat necrosis that happens post-surgery. But as in this case, we see that there is scarring which is there in the upper outer quadrant. The skin is thickened, retracted. The nipple is distorted. And besides that, there is a small hyperdensity which is seen along the scar with irregular margins. So if we see such a lesion which stands out, basically what we see is any lesion that stands out beside the scar with irregular margins, then we definitely go ahead with further imaging of this lesion. So personally, I would like to do an ultrasound first. If we can see the lesion separate well and good, we can do a histopad directly. After dense scarring, it may be difficult to differentiate between scar and recurrence. Then MR is the modality of choice. Contrast enhanced MRI, I will advise.
So in this case, you would like to go ahead with an ultrasound.
Yes, first with an ultrasound.
For some
If I can
additional
see the lesion with spiculated margins besides the scar, I'll go ahead with the biopsy. And if not, and if it's difficult for me to distinguish, then MRI. Before
Dr.
the
Richa,
biopsy.
will addition of Tumour help in differentiating scar versus recurrence?
So Tumour will show the margins of this lesion better, and it will also help. When you see the scarring, we see on Tumour that it is more towards the edges of the Tumour, like on the first initial and the last slides of the Tumour. And this lesion will stand out besides the scar. So Tumour will definitely have an edge on 2D mammography.
Mammogram, yeah.
Can I also ask a question here with from Dr. Richa, because it's a very interesting thing. Would you prefer doing a MR or just a CEDM, contrast and digital mammography would be better in this case? How would you go about it?
See, we can do a contrast enhanced digital mammography as well, and definitely on if it is a recurrence, it will take up contrast on CEDM. So in our institute, since we don't have CEDM, so we do MR to distinguish between scar and recurrence if need be. But even CEDM will show the recurrence and separate it from the scar.
Generally, after the surgery, there are surgical clips. So how difficult it is to proceed with an MRI in such cases?
So surgical clips normally don't cause any significant artifacts on MR. We see the surgical clips, but we do post-contrast subtracted images on which there is no significant artifact which we see, and it's not a challenge.
Dr. Richa, there's one question for you. Now in the era of oncoplasty, we now do a lot of complex oncoplastic procedures. So would you still recommend that we follow these patients up with only mammogram, annual mammogram, or would you like them to have MR to detect early recurrences?
So in average risk patient, mammogram is good enough. But if it is a high risk patient with personal history of breast cancer, then we can alternate MR with mammogram. 6 months.
Okay. So the choice, I mean, the procedure
Choice is on
she has
the
undergone.
risk status of the patient. Generally, MR, yeah, if there is a doubt, if there are some suspicious calcifications, if we see something more dense, separate from the scar, then we will definitely go ahead with the MR.
Okay. Because sometimes these, post complex oncoplasty, some dystrophic calcifications might interfere with your interpretation about whether it is a, dystrophic calcification or something new happening inside the breast.
So dystrophic calcifications generally have a very typical appearance on mammogram. They are just scattered and coarse calcifications, central lucency along the scar. But in case, what happens is during the initial development of those calcifications, they may appear amorphous and suspicious. In those cases, and if the patient is high risk and we have a history, then we can go ahead and do an MR.
Yeah, thanks.
Okay, so her mammography was done and the findings were confirmed. It was correlated with tomosynthesis also, and we found 2 new lesions adjacent to the principal lesion. On ultrasound, the findings were confirmed, and the overall size of the lesion was around 3.7 into 1.8 centimeters. So for the sake of discussion, we have included this picture. Actually, this is not of the same patient. It is of another patient. She was a post BCT and on follow-up. On follow-up mammogram, adjacent in the region of the clips, the mammogram reported a suspicious lesion. So, Dr. Richa, would you like to comment upon this mammogram? Dr. Richa, you're mute.
Okay, sorry. So as you can see, this lesion which is seen along the scar is showing some areas of lucency in the center, although it has irregular margins. So one possibility is that it could be an area of fat necrosis. If we follow this up, ultimately this area might develop post-dystrophic calcifications. But yeah, at the outset, it appears irregular, and sometimes even to distinguish between fat necrosis and recurrence, also we have to do MR in such cases.
So we
So
should
as
go
I said, and during the development of fat necrosis, still the calcifications are well established. It is basically suspicious, and then further imaging, or we can do an ultrasound. If an ultrasound shows an area of increased echogenicity along the scar, then it confirms a fat necrosis.
Okay, so actually she was then undertaken for a, yeah, pardon.
Was she further investigated? This
Yeah,
lady?
yeah, she was further investigated, and a biopsy was done from this lesion. It was negative. So do you suspect that, I mean, is this lesion so much suspicious that we should go ahead with the second biopsy, or like we can leave her for a follow-up only?
So this lesion, see, central lucency indicates some area of fat entrapment within it, although it has irregular margins. So we could have done MR for this patient, or do an ultrasound. And if the MR showed it to be a fat necrosis, then there was no need for a biopsy. Unless MR also does not show central fat and it shows only rim enhancement, then again biopsy is required.
Yeah.
So Dr. Safalta, over to you.
Hey, so conatal biopsy was done from this patient, and the it was showing ER positivity 6/8. PR was negative, HER2 was negative, and K67 was 20 to 22%. Now, next slide, please. Previous slide. So, what you will do in this patient, Dr. Ankur?
Ma'am, already has spoken about this, that we will first rule out the systemic disease by doing a PET-CT scan, as we have confirmed the disease. One thing I would like to add, as this is a recurrence, and now we have any genetic assessment tests. So I would like to offer this patient a comprehensive NGS. And in case patient is not affordable for comprehensive NGS, then at least BRCA gene with MLPA to rule out the one of the most common cause of this recurrence.
Yes. So,
and then I will like to go for an ECG and echo to look at the cardiac status.
yeah.
And then I will discuss this case in Tumour board, whether to go for upfront surgery or whether if I will decide to go for NSCT.
Okay, so next slide, please. So PET scan was done in this patient, and it was showing there is a heterogeneous nodular enhancement of soft tissue lesion, which is almost 2.3 into 2 centimeter, and right breast was normal, and there's no other evid abnormality anywhere in the body. Next slide, please. So treatment given so far, it was left mastectomy with LD. Now, with Dr. Vaishali.
Yeah, I will take over
Yeah.
now. Would like to bring Dr. Garvit again into discussion. Dr. Garvit?
Yes, I'm here.
Yeah, you're here. So Dr. Dev has already clearly mentioned about the factors which help us to decide what will be the surgical plan. However, I would like to know from you, what is your, what is your decision-making process in such a situation? Whether, if the patient wishes to go for a breast conservation surgery, what is going to be your take on it, and what all factors would you like to consider before you can offer her?
So, like Dr. Dev already mentioned in his presentation, so a DFI is something that plays the game here.
Yeah.
My decision is going to be based on the DFI, and like we know, 17 years of DFI in this case, we can offer breast conservation to this patient, provided my radiation oncologist is ready for a reboost.
Right.
And second, obviously, it is going to go through an MDT, and if the whole MDT agrees and the patient is at 60 absolutely certain that she wants a conservation with a risk attached and a tag attached that there are higher chances of local recurrence, although it does not mean it does not change anything in the overall survival.
Right.
But the patient has to understand that a local recurrence would mean the whole cycle being repeated again.
Right.
So that if the patient understands that, then yes, I'll be able to offer her breast conservation surgery. Depending on the size of the breast, depending on the size of the tumor, whether or not an oncoplastic procedure is required, since it's an upper outer quadrant and she's already undergone a quadrantectomy earlier, there's a good chance that she will require some sort of a reconstruction there.
Absolutely. But would you like to, start the treatment with chemotherapy and then maybe consider her for surgery, or would you, in general,
So
offer her?
It would depend on the IHC.
Yeah.
I would take it as an upfront case. Here, look, in an ER positive tumor, although she's PR negative, which is considered biologically slightly worse than ER/PR both positive.
Yeah.
So I would offer her surgery first. It's an operable disease. There's hardly any that I'm not sure whether you mentioned anything about the disease in the axilla, although PET is not a good way to see the axillary recurrences, but any which ways, I would like to go for surgery first.
Yeah, so I was going to come for axilla, afterwards.
Okay.
Yes, in her case, the axilla was assessed, although it was not, mentioned in the case. And she had previously undergone axillary dissection, and this time around, the axilla did not show any suspicious finding. So in such a situation, obviously, I'm sure everyone agrees that axilla does not need to be addressed again. However, in case if she had undergone sentinel node biopsy beforehand, and if she had not shown any suspicious finding in axilla, what will be your approach to axilla? Would you do a resentinel, or would you go for straight away axillary dissection for her?
I am not comfortable with the resentinel, especially when a quadrantectomy has been done. The lymphatics of the breast, the original anatomical lymphatics of the breast has been tampered with. We don't know how after all the exercises and massages that we tell the patient to do, how the new lymphatics have formed. I will not be comfortable asking for a new or suggesting a repeat sentinel lymph node biopsy for this patient. I would rather clear the axilla, or at least do a level 1 and 2 to be sure that we are not, or level 1 at least to be sure that we are not missing out any disease in the axilla if she's had a SNB prior to this.
Right. And more so over because she had undergone surgery in the upper outer quadrant. So that is also another reason for, difficulty in doing sentinel node biopsy. And in case if she had, obviously, in this situation, she had undergone mastectomy, and because the skin closure was difficult, LD flap was used for, chest wall cover. In case if she had wanted to go for, breast reconstruction, how comfortable would you be to offer reconstruction at this outset?
So at this time, again, it depends on the patient, because breast reconstruction in her case is completely cosmetic. There is no change in the oncological outcome. She has to understand that she's already had one local recurrence. And after that, there's a chance of recurrence, which is slightly, although the DFI says that this is a good chance that this is not really a local recurrence, it's a second primary.
Yeah.
If he's insistent on it, yes, I can offer whole breast reconstruction, because that's not going to change the outcome for the patient.
Yeah.
Yes, it's big surgery. Yes, I would want to know what the motivation of the patient is. If she's someone who absolutely does not want to get up from the table with a flat chest, I would not mind offering her, especially looking at the DFI and how well she's gone with the previous disease.
Right. And obviously, we have to explain to her about the possibilities of slightly higher risk of complications because of the previous scarring and radiation.
Previous scarring, although the previous RT has been quite some time back.
Yes.
And all the pre-op workup to find out which arteries are possible to anastomose and everything. Based on that only, I'll offer.
Yeah. Thanks, Dr. Garvit. Moving on, Dr. Prekshi, over to you.
So she underwent mastectomy, and it was grade 2 IDC. Notes were addressed earlier, so it was PT2 NX, and the max tumor size was 3.5 centimeter. Margins were free. So choice of the systemic therapy, Dr. Spalta.
Hi. So Dr. Neha. So what will be the choice of treatment in this patient? and whether you will give any adjuvant treatment to this patient. Dr. Neha, are you there?
Yeah. Yes, ma'am. Thank you for the question. So this is a very interesting case that now we have somewhat like a recurrent early stage hormone positive breast cancer in a woman that, though I have not exactly been told or I missed it, that she's
50
probably
years.
perimenopausal, I'm guessing at 50.
Yes.
So yeah, so had this been an upfront case, we're talking about second primaries or new primaries here, we would have probably done either if the patient was affording a recurrence scoring and we would want to know the menopausal status, or if not affording, then a predict score we would have applied. But in the recurrent setting, we cannot really 100% differentiate between the two. So using these parameters would probably, it's not evidence-based as such. So the only thing concerning for me here is one, that she's quite young. She's just 50. And secondly, the KI 67 is about 20%. So given that we're thinking that it's a node negative disease, I would want some chemotherapy and I would want it before the radiation, and possibly an anthracycline free regimen, maybe like PC or paclitaxel carboplatin. And that I would want to follow up with adjuvant endocrine therapy for at least 5 years. Again, depending on the menopausal status of the patient.
Yes. So do you change your treatment according to the biology? Like this is ER positive, PR negative. If it is ER and PR strongly positive or HER2 positive, so will there be any change in the management in the adjuvant setting?
No, definitely. So although the evidence overall in systemic therapy in recurrent setting for IBTR is not really strong, Sir discussed the CALO trial, which is one of the good RCTs available in the domain. Rest mostly we have retrospective. So the support for chemotherapy in hormone positive breast cancer is less than for TNBC or HER2 positive. If it's HER2 positive, then we obviously have to add a HER2 directed therapy. And that again is an entirely different discussion. In this patient, since the PR was negative and the KI was slightly higher, that's why I'm erring more towards a bit more caution and advising at least 4 cycles of adjuvant. Had this been a strongly PR positive and had she been maybe 65 or something, then older age or a lower KI 67, these were the parameters I would consider clinically and on the histology to not choose adjuvant chemotherapy and go for endocrine therapy.
You are absolutely right. So, Dr. Ankur, so Dr. Neha has decided to give chemotherapy. Which chemotherapy
Yes,
you would like to give in this patient?
Ma'am, I agree with Dr. Neha regarding the facts given. And in case in this patient, as she has already received epirubicin-based chemotherapy earlier, I will like to offer either paclicarbo or docetaxel and oxan combination.
Okay. So, don't you think that we can reintroduce anthracycline in this patient?
Ma'am, it depends upon the performance status and exact cardiac status. We have to calculate the dose that was previously given. If we go with the standard dose, 9 into 6, 540 milligram, she has already received probably.
Mm-hmm.
So that's a very small dose left. We can only give 2 cycles or 2 or 3 cycles of epirubicin-based chemotherapy. And in case, yes, if there is strict parameter, then with the introduction of dexamethasone, then we can add further cycles. But it's better to avoid the risk, and we can continue with the paclitaxel and carboplatin, which are pretty safe drugs.
Yes. So, see, we can give paclitaxel n number of times. You have seen multiple times. You have to repeat after recurrences. So even with the anthracycline, it is like pegylated lipodox you can use in this patient. So lipodox also, like the this can be given, in fact, till progression. It was a randomized trial which was published in JCO in 2009, and they've shown that there is 20% increase response rate in this patient. So actually here the patient is ER positive, just 2 centimeter lymph node, 2.3. So we can skip anthracycline also, but being a PR negative with a high K67, if we want, we can introduce anthracycline in this patient. So it was a good study of 751 patients. So that's a good, and it is not in the recurrent setting, it is in the metastatic setting that the patient was reintroduced anthracycline. So pegylated lipodoxal can be given as such, what I feel. Next slide, please.
Dr.
So if the
Safalta,
patient,
at this point of time, we just forgot to ask our pathologist, like, how would you like to differentiate between a new primary morphological features? Dr. Dheeraj, are you there?
Yeah.
Yeah. So, hi. So, would you like? How would you like to? How would you differentiate between a true recurrence or a new primary based on the?
In this particular case, it is very difficult just because it is around 2006 case. It's around 19 years ago. But usually, what we did, we usually compare the both sides. Okay, we see the DCI around it or not. So we compare it, but it is really difficult.
So, okay, we cannot differentiate on the basis of pathological findings, right?
Yeah.
And how often do you see there are different biologies, and how many times they are the same biology, like in, or how, how difficult do you find to assess a specimen pathologically after the patient has received radiation therapy, chemotherapy? So do you find any difficulty in assessing that specimen?
Pardon, your voice was not clear, so I couldn't.
Sorry, now is it audible?
Yeah, please.
Yeah, so I was asking, do you find any difficulty in assessing a specimen in a post-radiation, post-chemotherapy patient?
Yes, of course. Radiation, change a lot in the morphology. There's a endothelial proliferation. Sometimes the endothelial cells look like the malignant cell. They are enlarged, they are edematous, they have a macronucleoli. So the history is very important. And then we will put the CD31 for the endothelial cell to see whether there are endothelial cell or the tumor cell. So it is very, very difficult sometimes. So you need to do the immunohistochemistry and you need to compare on the morphology also.
Okay, so IHC will be like additional information.
Exactly. Sometimes the radiation changes mimic tumor very, very much.
Okay, so it is in breast also.
Yeah, everywhere, especially in head and neck tumor, the breast tumor, urology, the prostatic carcinoma is very, very difficult. So in breast also, the same problem arises after radiation.
Okay. So, thank you, Dr. Dheeraj. So, Dr. Safalta?
As both my panelists are not willing to give anthracycline again. So actually anthracycline, when it was reintroduced, it has caused almost a similar cardiotoxicity as it was in the previous. It is like less than 1 to 2% in that randomized trial. So I just wanted, if the patient was ERPR positive in the first go and now also ERPR positive, so whether you would like to, initially she received anthracycline, that time it tamoxifen, and that time it was not, we don't have the concept of tumor hormone suppression. So would you like to reintroduce tamoxifen in this patient now, or you would like to give letrozole and the hormone suppression? Dr. Ankur, what would be the hormone
condition,
choice?
Ma'am, in the patient is already, I think, getting the perimenopausal as per the age group.
Yes.
So it was shown earlier. So it's better to go for an LH and FSH ratio. And if it is in the postmenopausal status, then definitely I would like to go for anastrozole or that is letrozole. In case the patient is still premenopausal, already patient is have a recurrence on tamoxifen, that makes patient a high risk on hormonal patient. So I will like to combination. I will still go for anastrozole, or will go for surgical oophorectomy or radiation induced.
If arbitrary, if a case is there and she was postmenopausal in the first time and there is a recurrence, that time it was anastrozole or letrozole was given, and now the recurrence, and she's postmenopausal as such previously also and this time. So what would you like to reintroduce? It has been like patient has stopped letrozole and after 3-4 years, 5 years down the lane, the patient has IBTR. Now, which hormone therapy would you like to give in the adjuvant setting in this patient?
In this case, when there is a time gap between the stoppage of anastrozole or letrozole,
Yes.
and then patient has relapsed after 3-4 years,
Yes.
then I would like to reintroduce the same drug.
And would you like to see about the bone density or the patient, what
Yes,
kind
ma'am,
of
that
side
is
effect the patient?
that will we monitor as per standard criteria. The DEXA scan will be done. In case patient is having osteoporosis, we will start him on bone modifying agents like zoledronate. In case severe osteoporosis is there, then it's difficult to give anastrozole, and we have to get along with either this tamoxifen, or we can go with the higher choice of drugs like exemestane in that setting.
Yes.
And is there any guideline regarding the duration of endocrine therapy in the recurrent setting? Is there any, for how long
No,
will
ma'am,
you advise?
No. How long will you advise? There is no guideline, but how long will you advise?
I don't think that there is strict guidelines available in the case of a relapse, but we will follow what the data which is coming from the primary recurrence. At least 5 more years we will give.
5 more years. If she continues to tolerate it.
If she continues to tolerate it.
Can I ask one question here?
Yeah.
So Dr. Ankur initially had mentioned that he would be doing germline testing for BRCA1 and BRCA2. And what if it comes positive? Would your
then as per, if it is positive, then as per Olympiad trial, we can add the olaparib to this patient.
But Olympiad, okay, fair enough. Then I mean, one way or the other, whether in the adjuvant setting or you consider it as, yes, fair enough. And one more question, sir, to you is like the arbitrary case that we were discussing. Would you also consider CDK4/6 in a recurrent setting with when deciding hormone therapy for?
Till now, the data of CD4/6 inhibitor is not there in the adjuvant setting. So they are claiming that ribociclib data is going to be published in ASCO 2023. But till that data is available, we have to wait.
But abemaciclib has been is available in the adjuvant setting.
Abemaciclib is available, but that is in lymph node positive setting. I don't think this patient qualifies for that monarchy criteria.
Fair enough. Okay. Thank you so much.
Dr. Neha, do you have any other thought process in the case, in BRCA positive case, or in the patient's the questions which I have asked?
So I do agree that if a patient for first deciding what hormonal therapy, so I agree with Dr. Ankur that if it's not a recurrence that is happening on adjuvant hormonal therapy or within the first 2 years of adjuvant hormonal therapy, we are safe to re-challenge the drug if we have to. If the patient has tamoxifen, then AI becomes a natural choice. If the bone density is okay and no contraindications, he is able to tolerate it. If the patient has received AI before and it is an early recurrence, one option emerges, that of SERDs, which is fulvestrant for now. Maybe we'll have better molecules in the future. And this will be given for at least 5 years, extrapolating from the first line setting. Secondly, the point of olaparib, definitely there is an overall survival benefit with the drug. So Olympia, it actually has an OS benefit in the adjuvant setting. So if the patient is BRCA positive, I would definitely add olaparib. But keeping in mind that this patient may have received anthracycline, there is a risk of leukemias with olaparib also. So that counseling and that discussion needs to be taken with the patient. Regarding abemaciclib, I am not a very strong supporter of CDK4/6. I don't find the evidence convincing. And the cost-benefit, risk-benefit ratio to me does not appear that promising. We don't have overall survival benefit. We definitely do not have quality of life improving. So I would probably refrain from adding CDK4/6 as of now in this patient.
Yes. Thank you, Dr. Neha.
So there's a question from audience. If Dr. Dev is here, we can maybe ask him to address that. Sir, are you there? Dr. Dev?
I think Sir has left. Has left.
Okay. Dr. Garvit, would you like to take that question? It is regarding
marginal
marginal recurrence.
So technically any recurrence which is happening within the 2 centimeter distance of the margin is considered as marginal recurrence. The term is started from the fact that not the margin of the tumor, but the margin of the radiotherapy boost. So wherever the boost was given, if a tumor recurs at the margin of the boost cavity, is what is considered as marginal recurrence. And as we know, when we are planning a boost, the radiotherapist generally will include a safety margin of 2 centimeters while giving the boost. So that's where the definition comes from. So if you're getting it within the 2 centimeters of the cavity, it is called as marginal recurrence, or actually at the margin is being called as marginal recurrence.
So again, yeah.
Yeah, I'm here. I'm Dr. Dev. I'm here.
Okay.
I agree with Dr. Garvit's views. Absolutely.
Thank you, sir.
Yeah, thank you.
So my question to Dr. Dev would be, in case now we are doing more and more of oncoplasties, and occasionally we do come across patients who come with, hard lumps, and we generally, have a very, we are scared about whether it is fat necrosis or, a true recurrence. So how do you deal with such cases, especially when we are doing, complex parenchymal mobilization or these flaps, local flaps we do, and we occasionally come across fat necrosis. So how do you clinically judge whether it is true recurrence or fat necrosis?
Yeah, Dr. Vaishali, I think that's a real sort of a challenge we face in routine practice.
Yes,
a lot depends on your background, how much experience you have, and what kind of a BCS experience you have. If you have around 10 years, 15 years experience, you have seen what is your true recurrence rates and how the breast feels, how the recurrence feels. The experience matters a lot, because every induration or every post-op change, if it starts triggering a sort of a reaction, if you start thinking about recurrence, it creates a big chain of events I have seen going for a lot of imaging, biopsies. So I think the experience matters a lot. That is why I keep all these patients closely under surgical follow-up, predominantly under surgical follow-up, to be seen by your colleagues along with you. They should not be left to the juniors for routine follow-ups like any other BCS. I'm not blaming them. I think because it needs a lot of judgment, and suddenly something triggers the patient, the anxiety levels go up, the PET scans, the MRIs, the biopsies, the whole downstream chain we need to take into account. But practically what I look at is the index cancer risk factors. So if the index cancer is low risk, my threshold for going for immediate investigations, too many investigations, I will keep them low. I closely follow them up. I keep it 3 monthly intervals, monitor them, how they are doing. But if the index cancer risk factors are high, then sometimes I do over-investigate to rule out a local recurrence or a second primary.
Yeah, I'm sure. In fact, now because of the addition of such wonderful imaging, technology, we are able to identify whether they are true recurrences or fat necrosis. So that helps us to prevent unnecessary, biopsies in such a situation. I'm sure you agree to that.
Thank you. Thank you. Yes, yes, definitely.
Yeah.
But you see, I think I think the expertise of the radiologist is also very important.
Absolutely, absolutely,
absolutely. So that is where, because this is a very difficult field, even if you raise a small doubt, if you leave it like clinical correlation or something, then they go into a spin of the anxieties, the biopsies, the whole chain starts. So the expertise and the confidence of radiologists is extremely important.
Absolutely, sir. Rightly said. Thank you.
Thank you.
Dr. Goel?
Yeah.
Please. Yeah, would you like to add anything or?
No, as such, I would say it has been a wonderful discussion, but maybe I could ask both Dr. Dev and Dr. Garvit about their personal experience in the sort of one reconservation and second re-sentinel node biopsy.
Okay, Dr. Garvit, please.
Okay, sir. Yeah, you put me in a spot here. So re-sentinel lymph node biopsy is definitely a no-no for me, sir. I don't find the data convincing, or in fact, hardly any this thing except other than few case series which are available on the in the literature. So I'm not convinced with the re-sentinel lymph node biopsy. Definitely about a re-BCT with a DFI, I may still consider it. Frankly, in my experience, there have been 2 patients so far, and it has been I've been in Tata Hospital for good 10 years, and now I'm in Nanavati. I have still seen only 2 patients who insisted on a conservation after having one local recurrence. Where we ended up doing it, we boosted with a different energy source. We did a reboost, but then obviously it was an MDT discussion. The patient agreed to the risk factors of local recurrence, and after all that detailed discussion with the patient, we were able to offer that. But that's the vast experience of 2 cases here, sir.
Yeah. I agree with Garvit. I think, Arun, I think this is a field where we have to be really treat very cautiously. Since this is going to be a salvage situation, we need to look at the patient's desires, what kind of challenge he can take up. Re-SLNB, even I don't venture too much into re-SLNBs. In a salvage situation, it is always axillary lymph node dissection. For a re-BCS, I think very select patients, very select. Like if you see our own series of 1,000 breast conservations with a local recurrence of 3%, out of all the local recurrences, I think the re-BCS was considered in less than 10% of patients. 90% are going for salvage mastectomy. Salvage mastectomy.
Thank you. Thank you. So I think that gives a message to the audience in terms of choosing the surgical approaches in the setting of IBTR.
Dr. Prekshi?
Yeah, so I want to ask Nidhi ma'am. Ma'am, are you also convinced with the sequencing of the therapy after surgery, or you have a different approach after surgery? We should go ahead with chemotherapy and then radiation therapy, since it is an IBTR.
In all probabilities, especially the case that you had put forward was a left-sided tumor, and here the cardiac toxicity is of prime importance to me. So, and whatever literature we have, though there are no stringent guidelines to guide us, but in all probabilities, the patient would be only taken up for partial breast irradiation and not the total breast irradiation. And having said that, it would be better if we do IORT, which is ideal for these cases, where you can spare almost everything except the tumor bed where you actually want to radiate. But the problem is we do not have an access to IORT in most of the centers. And the next best thing to do is an intraoperative brachytherapy implant, which comes handy under the same anesthesia. Right at the site, you are able to define the targets very well. And you go ahead with the interstitial implant, sparing the skin and the underlying vital structures like the heart and lung. And that is the best thing to do. So I would prefer to do the radiation first ahead of systemic therapy in these cases.
So if we opt for like brachytherapy, then yes, radiation first. And in case the patient is not fit for brachytherapy, or we take the patient for external beam, then what should be the sequence like? Then also radiation first and then chemotherapy?
Then it is debatable. I mean, as per the standard primary tumor, we can go ahead with the second, after the systemic treatment also. But still, I would say it entirely depends upon how the patient is counseled and how they are made to understand. This is a shorter treatment, safer treatment at one go under one anesthesia. I mean, I don't think the patient would deny that. Patient would definitely opt for that.
So IORT is the method of choice, and yes, radiation first.
But
so,
the availability is hardly, it is very scarce. So it is better that we opt for brachytherapy in such cases, and interstitial is the ideal thing to do. Balloon and all, they are not, the recommendations are not of any high level.
Okay. So, ma'am, actually, this patient underwent mastectomy. What do you think? Is there any indication of radiation therapy in this case?
So it was it is a gray area, I would say, even in the upfront cases. So here, of course, we can avoid this if the patient is going to receive systemic treatment. It is a borderline case. There is no LVI, there are no lymph nodes, and it is 35 mm. So we may avoid it. It is not required.
And what are the indications of PMRT? Like they are same as that of the primary setting or in?
Yes, so PMRT, it is more or less the same, especially if it were TNBC, I would not hesitate in treating this patient also.
Okay.
And of
So-
course, I would include DIBH in this case. Now that we have then access to this, she may not have received that earlier in 2006, but now since we have availability of this modality, I would try to incorporate that and avoid whatever I can in terms of cardiac toxicity.
Okay. So, ma'am, if we take this patient for like brachytherapy, what dose and what fraction size for HDR would you like to consider?
So I would go in for 35 gray in 10 fractions with 6 hours apart, and that should suffice. With an adequate margin, that should suffice.
And for external, whether are you comfortable giving her hypofractionation or ultra hypofractionation in the recurrent setting?
Since the data as such for PMRT in re-irradiation or recurrences are not very much, I would not like to indulge into these fractionations. I would go rather for conventional.
Suppose it would have been a BCS, not PMRT. Suppose if it would have been a BCS, then would you like to go ahead with 45-50 or you can go with 14-15 or 13-5?
The pathology that you had shown, I would not go for whole breast irradiation. I would go for partial breast irradiation only.
Yeah.
And there I have the advantage of doing a hypofractionation also, because the target volume is very low. I can easily go for hypofractionation. Shouldn't be a problem.
So hormone therapy has already been discussed.
There is one question in the audience. He's Dr. Asif. He said that there is no, he is not a doctor, he's not a clinician, he's a scientist, and he's asking that is there a procedure for localized adjuvant chemotherapy with drug-eluting implants? If so, and has been any proven improvement, or what are the challenges? So,
ready.
and Dr. Ankur, Dr. Neha, if you want to say anything about this case, about this question.
Ma'am, currently it's a good scientific rationale which may be coming in the future,
Yes.
but currently we don't have this data in the breast cancer. There is a data that in ovarian cancer, in some gastric cancers, we do with intra-abdominal chemotherapy during the surgery, which is termed as the HIPEC. But there is no such data of adjuvant therapy giving to a localized center, to localized organ in breast.
Localized lesion, yeah.
There is
localized lesion in breast.
There is one trial which is being conducted, which is giving localized chemotherapy via it's done for head and neck and breast, or basically superficial cancers. But the data is not out yet. The result is not out yet. It's an ongoing trial.
So, Dr. Garvit, what is it? Some sort of an implant, or is it?
It's not an implant, sir. It is being. It's basically they push in chemotherapy through venous. Vein flow, and it goes into the tumor itself. And it's basically local delivery which happens into the. And they are combining it with some sort of an electric current. I am not really this thing with because it was happening in the head and neck unit at that time, and it's called electrochemotherapy.
So that is electroporation, I think, but
Yes,
it is basically electroporation, some sort of a transcutaneous application, and then.
Yes.
So overall, I think in solid cancers, this problem is going to be limited because of the degree of coverage of area are surrounding the gross tumor. So that would always be. So intracavitary, as Dr. Ankur said, is okay, where the whole cavity can get, and you have to make sure that the whole cavity is receiving the drug. There are no adhesions and all. So I think that there may be a theoretical basis, but it's probably a long way off.
Very, very this thing. And what right now what they're doing is they are doing it in a palliative setting, not really.
Yeah.
Not an adjuvant setting. Yes.
So there is a question regarding addition of capecitabine in case if this was a TNBC recurrence. Anyone, Dr. Ankur, Dr. Neha, would you like to take that?
Ma'am, in case it was a TNBC, then we will start preferably with a neoadjuvant chemotherapy in this setting. And if the patient doesn't achieve PET-CR, we will give adjuvant capecitabine.
Okay, so we will treat like you treat in a primary
TNBC, like we did in a primary TNBC setting.
Okay. So, Rajiv sir, would you like to add anything? Any question? Any comment?
I will like to add only one comment that since breast cancer itself and particularly ipsilateral breast cancer recurrences has to be a teamwork where you have to have a good pathologist, excellent radiologist, and of course the radiation oncologist and chemotherapist. So that's become a teamwork if you want to have a better results in the particularly recurrent cases. Of course, primary cases, we all know that it's a teamwork, but ipsilateral recurrence, which is rare, none of them us have a very large experience of those cases. We have to work very judiciously and thoughtfully with a multidisciplinary team to manage the best manner to these cases.
Right. I think there are no questions, but I would like to ask Dr. Garvit or anybody for that matter, because this is a recurrent setting, is there going to be any different way we follow these patients, and how stringent, how frequently, and what all modalities would you do in follow-up? Will it be any different?
So for a mastectomy, which has been this thing, I don't think the follow-up is going to be different. I would like to follow up like a regular breast cancer case. And based on the, like it was earlier discussed in the panel, that depending on the risk of the patient, what she carries, I would not like to add an additional investigation just because it's a recurrence after such a long time. Yes, if we did a germline testing and if she tested positive for one of those deleterious mutation, I would want to add an MR for follow.
And if the patient is has got done BCS, in that case also, you'll be following, or MRI will be added? Because it will be very difficult in mammogram again.
But that would be just as difficult whether you're doing it when you're doing a mammogram. If the breast is not dense, the mammography is going to be equally sensitive whether you've done one surgery or two. If I don't know if Dr. Deo would want to weigh in here with something else, but I think this is what I feel. Sir, any comments on this? I think so is tuned out.
The follow-up will be more of a challenge in these cases because there will be more fibrosis, more tissue handling, more radiation, more surgery. So it will be more difficult. So I guess we will have to go in for more modalities like mammo and PET rather than sono and mammo, because they will have their own limitations.
Yeah.
Maybe a tomomammo may be a little more help.
Yes, sir. I don't know whether a PET, adding PET to this situation, will it make a lot of difference? I don't.
No, not for the routine follow-ups, but whenever there is an element of doubt.
Yes, that I think would be with any dense breast, that if there is an element of doubt, additional test like an MRI, like any other addition of tomosynthesis, addition of digital mammography with contrast enhancement, all this can be done based on what the first mammogram on the first follow-up shows. If the first follow-up is crystal, if it is a fatty breast, does not show any, I would like to follow it up with mammograms at a regular interval, at the interval that I would follow up in an upfront case.
So will you have a low threshold for ordering a PET scan during follow-up, because there is a heightened anxiety now that it is a recurrent disease?
So
anxiety both for the clinician and the patient.
This is another. I think it's a discussion which is going to take a long time, because once we start talking about PET scans on follow-up, then we move on to ctDNA on follow-up, and then we move on. I would not change my this thing based on. I would still want to ask for a PET only when the patient is symptomatic.
I think I can also just chip in here. Say covering anxiety using PET scan may not be a very good idea, because anxiety is going to recur after a few days only. So you cannot really take care of that. So a better understanding is more important. And I think about the imaging when it comes to surveillance, probably it is not a particular imaging as such. You use one imaging for primary surveillance, and whenever there is an element of doubt, a multimodality imaging may be relevant in a complex situation like this.
Yes. Yeah. I think because of the scarring which is there and now in this recurrent setting, obviously alone mammography may not be able to give us the complete answer. So in this situation, probably multi-modality imaging will be useful. So I think we have actually covered everything bang on time. So if there are no more questions.
So thank you to all the panelists and the moderators for the panel for this exhaustive discussion. A very good case-based scenario, and then using all sorts of permutation combinations to, you know, grill all the panelists. And I must appreciate all the panelists who have been, you know, excellent with their experience and their answers to those questions. And very happy to see the audiences also chipping in with some very interesting questions. It's been a very good panel discussion. Thank you to all the panelists, the moderators, Dr. Deo sir, for also, you know, staying back for the panel. I would like Dr. Rajiv Agrawal sir to, you know, for the vote of thanks and the closing remarks. Over to Rajiv sir.
Am I audible?
Yes, sir.
So before I go for a formal thanks, I will just like to make a clarification that this anti-cancer trust and the focus studies in breast cancer is the brainchild of Arun Dinesh and Vaishali. And I am a very small worker in this whole affair. I think we had a wonderful meeting as usual, and we have finished in time. My sincere thanks to my long-time colleague and friend, Dr. Dev, who was the sole speaker, but he beautifully described and gave an overview of the ipsilateral breast cancer recurrence, which is, none of us have a very large experience. My sincere thanks to all my panelists, Dr. Chitkara, Dr. Bansal, Dr. Patni, Dr. Ankur Vashne, Dr. Dheeraj Gautam, and Dr. Neha Pathak. Of course, this event is never possible without nice ideas. My thanks to them. Of course, almost 150 delegates were there. They are truly deserve our thanks. And particularly my thanks to my younger colleagues, that is Prekshi, Safalta, and of course, Chirag. They are the backbone of this seminar, and they do a lot of groundwork and hard work. Thank you very much, and good night.
Sir, just one moment. Yes. I think it is very great of you to talk about being a small worker, but I would say you are the senior member of the team, and from the time I came into private practice, I have been associated with you. So whether I am working with you or not, your friendship, your guidance is always very, very important.
We are very,
whether your name is there in the trust members or not doesn't matter. And I believe we believe in the power of teamwork, and every person contributes with their best possible effort. Thank you.
Absolutely.
Thank you, Dr. Rajiv.
Thank you.
Thank you, everyone.
Thank you so much.
Thanks to everyone. Thank you.